Thank you for having me in this conference. My name is Minhaj Siddiqui. I will be discussing the urologic perspective on current emerging role of multimodality imaging in radiogenomics. Thanks to Faye and all the organizers for putting this together. I've been coming to the AdmiTech summits for years now. It's one of my favorite meetings. I'm sorry we can't do it in person, but I'm glad we can kind of continue the tradition. So I have no relevant disclosures to provide. So how do we incorporate precision imaging and genomics into the management of localized prostate cancer? I think it all starts with the stratification of prostate cancer aggressiveness. And when you go from low risk to high risk and localized and advanced metastatic cancer, various treatment strategies make sense. And so at the low risk side of the spectrum, you have active surveillance, and then you could have maybe focal ablation, and then just whole gland treatment and whole gland multimodality treatment, and then systemic therapy. It's been shown and pretty well accepted, I believe now, that MRI can improve risk stratification for prostate cancer. Originally, we showed that in terms of comparing target biopsy to standard 12-core template biopsies, the sensitivity goes up to 77% from 53% in terms of diagnosis of intermediate to high-risk prostate cancer. The PROMISE study showed how you can risk stratify significant cancer based on MRI suspicion score of lesions. They used the Likert system at that time when they published this. And so you can see in the Likert 5 suspicion score, you have about an 80% enrichment of significant prostate cancer, whereas in the lower Likert scores, you have a 10% enrichment. What's notable here, I think, and it's something that's important not to forget, is that at the high level, you still have some patients with insignificant or no cancer. Therefore, MRI does not replace biopsy. Imaging cannot quite at this point replace biopsy for treatment decisions. Similarly, at the low levels, about half of patients have cancer, and 10% may have at the Likert 2, 10% may have significant cancer. So we often call these scans negative, quote unquote, but they're not quite negative for cancer, even though the scan itself may not be considered high risk. The next phase of all this is really trying to figure out, can MRI imaging and combining information, PSA, demographic information, be used to predict tumor grade? There's still a lot of work to be done in this space. We generated this nomogram a while ago to try to do this. You add up the various kind of point totals for the various kind of components, and then based on that, you go into points here, and you see that, okay, at 50 points, there's about a 40% chance of being Gleason 8, 40% chance of Gleason 7, 20% chance of Gleason 6, 10% no cancer. And so it turns out it's accurate about 70% of the time, which is not bad if you think about it, without any pathology, but still some, not good enough to make clinical decisions on. I think that risk stratification is only going to get better, and genomic profiling is going to be an important part of that. I think that these are going to be complementary. It makes sense that they would be complementary. There's been a huge growth in the space of genomic profiling. In the last 10 years, we've had a whole bunch of new genes being found and characterized. You can see here, the last 30 years, a lot of the work was being done in loci of genomic susceptibility. And then suddenly we have all these genes kind of being discovered. We have commercial products coming out utilizing information regarding some of these genes and just general patterns of genomic gene expression and whatnot. And so we have these biomarkers and stratification tools available. And they actually span the entire phases of care. So starting at the susceptibility phase, identifying patients in the general population who are at risk, there's the Stockholm 3 biomarker. For biomarkers of disease risk, we have things such as exosome DX and select MDX and me prostate score. For risk stratification, Oncotype, Decipher, and Polaris stand out. And for predicting treatment response, ARV7 got a lot of attention in the space. You can get genomic classified tissue on prostate tissue, say after prostatectomy, to figure out, things such as should you do adjuvant radiation. And much like the MRI, the GC score, the genomic classifier kind of stratification score, does show an association with grade group, which is reassuring. And so for grade group 5, you see enrichment of high GC score. For grade group 1, there's low GC score. But again, like imaging, um, what is worth noting is that at the low grade group score, there are some high GC scores, and at the high grade group score, there are some low GC scores. Now, I mean, the question is this kind of a inaccuracy in the system still, or is this actually reflective of patients in the low grade group side who will do more poorly and should be treated more aggressively, or patients on the high grade group side who actually won't do as bad as we think they will and may be treated more conservatively? I mean, I think there's some data emerging saying that the latter may be true, that GC score within grade group may actually help give further biologic insight into future disease behavior, but it's not, I would say, proven at this point. I put these side by side. This is the distribution of cancer aggressiveness by MRI suspicion score, and here's the GC score. And although it's not apples to apples because like the axes are a little bit switched up here, I think the distributions are strikingly similar, which I thought was fascinating. And I think even if you did a little bit of work to make it more of an apples to apples comparison, I think the distribution would actually probably pan out to be similar still nonetheless. The question is, are these kind of two modalities capturing the same underlying issue, or are they actually complementing each other? And I think that is actually where we need some more work and where we could really make a lot of progress, especially if we found out that there was some way that they were complementing each other and the two could be used together in meaningful ways. I think in terms of application of these tools into management, I find imaging very helpful for prostate cancer surgical guidance. I find it very helpful to see kind of where there's potential extracapsular extension. There's been studies to show that when surgeons were using MRI versus not using MRI, their margins rate improved. It is important to know that decisions should not be solely made based on margin stats. Now, this is an obvious extracapsular extension, but a lot of the time you might have something like this side. Okay, this side of the prostate may be called as extracapsular extension, and I may not be using the best example here, but so a lot of the time you have bulging, or you have kind of just good length of abutment of tumor against the capsule. It's not diagnostic of extracapsular extension per se, but suspicion for extracapsular extension is called appropriately so. It turns out about half the time that suspicion is actual extracapsular extension, half the time it's not. I've seen a lot of the time people kind of steer in one way or another based on this call, but it's worth knowing it's only right half the time. The genomic scores are finding use in kind of predicting future behavior. Here, this study which was a great study, showed how low GC score after a prostatectomy with high-risk features such as positive margin, extracapsular extension, patients with low GC score could be watched, whereas high GC score may benefit from salvage radiation. I think that in the space of lymph node involvement, the two modalities combined may actually turn out to be quite helpful. Right now, imaging to identify lymph node development is not very sensitive because it's based on size criteria. Size criteria can be misleading because you can have enlarged lymph nodes due to inflammation. PSMA is a very exciting test, which is rapidly proliferating after its recent FDA approval. There's been studies to show this was actually, you can see that by the authors, numerous institutions represented here. There's work showing that you can risk stratify for positive nodal involvement and PSMA, kind of utility of PSMA based on GC score in a population of 91 patients. A high GC score, a 0.1 elevation GC score based on the genomic test led to an odds ratio 1.4 that you would find nodal disease. And then, as I had mentioned earlier, these tests can also be used to stratify for treatment response. And so the ARV7 in particular is helpful. ARV7 is an androgen receptor mutation that lacks the ligand binding domain for androgen receptor. In this study that I'm showing here, 62 patients were metastatic cancer-resistant prostate cancer with the ARV7 were enrolled, and you can see how the ARV7 positive patients cluster both with enzalutamide and abiraterone actually in patients that have good response. There are some patients that did not fit the mold, but for the most part, it's actually pretty striking how much this segregated. So, in conclusion, precision imaging of genomics in prostate cancer can improve risk stratification at all stages of disease. The use of imaging for staging and treatment planning has some benefit, but more research is needed. And the genomics to reduce interventions such as adjuvant radiation in specific patients or target therapies also has a ton of promise, but requires some more research. Thank you again. I think that's always important to acknowledge all the kind of people involved with the different work that you do. Some parts of this were things that our group has been working on, and it's a pleasure again to join everyone.